everybody for joining us for another episode of Northern Virginia's Town Hall event. Appreciate everybody for joining on. We have a very special guest, Dr. Robert Mordkin, tonight. But before we get started, just a couple quick announcements. I'm sure if you're not already aware, just so you know, we have moved over the past month. And we're really excited about our new location. We are finally getting settled. It took a long time, but we're in the old Anderson Clinic building now, over near Shirlington in Arlington now. So we're all set, and please make sure you don't go to the old building. So hope to see you there, and that space looks great. The only other thing is that, just so you know, we also have both the flu and COVID shots. And so if you haven't gotten those, you can certainly get those at CVS or Walgreens or any other pharmacy, or you can come to our office and get them. But we do recommend that everybody gets a flu and COVID shot this fall. If you qualify for the RSV shot, we do not have that. But you can get that if you'd like again, at the local pharmacies, right? Now I will move on to our main event. I'm sure there are a number of people here on today who have seen Dr. Mordkin as their physician, because he's been around for a while and has got a great following. A lot of physicians, including myself, send our patients to him as our prime urology referral. Dr. Mordkin went to USC for medical school, and then came to the other coast to do residency at Georgetown in urology. And he was on the faculty at Georgetown for a while, for about 7 years, I believe it was, and then moved over to Virginia Hospital Center, where he's become a specialist in prostate and prostate cancer, including robot-assisted laparoscopic procedures, and including was the director of urology at Virginia Hospital Center. Dr. Mordkin has a wealth of knowledge and has taken great care of our patients over the years. So really appreciate you being here tonight to give us your take on the newest in prostate and prostate cancer. Welcome.
Well, thanks, Dr. Zweig. It's an honor to be invited, and it's great to see such a terrific turnout. I see some familiar names there, so in our guest list, which is exciting. I'm going to apologize right up front for two things. First off, for those of you that have seen me in the office or are my patients, some of what you're going to hear from me may sound a bit redundant, so apologies there. The second is that I am doing this from home, and I have two dogs, and if you hear them going bananas, it just means that they perceive that somebody is about to overrun my front door. So, please understand that. With that said, it's nice to get an opportunity to talk with everyone this evening around prostate cancer. I want to keep this pretty informal, talk a bit about sort of the history of the diagnosis, why I think it's important, talk about sort of the state of the art as it stands today and how we pursue it in our practice, in my practice, and then I really want to create an opportunity to allow all of you to ask any questions that you may have, and I think that'll probably spur on further conversation. So with that said, sorry,
just interject for one moment. So if you do have any questions, and as we go, you can put them into the chat box, and we'll save them for the end, but so you don't have to forget them. You can put them in the chat box, and we'll go through them as best we can at the end.
Great, thank you. So as Dr. Zweig said, I'm Rob Mordkin. I've been a urologist since 1998, a long time now. I was back at my medical school homecoming 2 weeks ago, and it's amazing how time has flown. But I'm also fortunate that I have my daughter at my alma mater. My daughter is a college freshman at my alma mater, so it's fun to be able to tread the same steps that I did 30 some years ago now. I don't want to totally do the math here, but in any event, what we want to talk about tonight, I think, is about prostate cancer and prostate cancer screening. It can be a challenging topic for patients, for primary care physicians, and certainly even for those of us in urology that deal with it on a daily basis. First off, why is prostate cancer important, or is it an important topic? I think it is an important topic because, well, many of you have likely heard sort of the adage that if men live long enough, they're all going to get prostate cancer. And there certainly is a kernel of truth to that, although it's not true that everybody or every man's going to get prostate cancer, but there is a kernel of truth to that. If you live long enough, you're certainly more likely to get it. But it should not be ignored in that it is the number 2 cancer killer of men. So it does have lethality associated with it, but it often doesn't get perhaps some of the same sort of urgency or press as some other diseases you may hear about, primarily because often the time from diagnosis to the time of potential death can be extended. And that's because prostate cancer, as a general rule, and there are always exceptions to the rule, but as a general rule, is a relatively slow-growing disease in most cases. But again, it is the number 2 cancer killer of men. And the statistic, to put it in some perspective, is that about 1 out of every 35 men are going to die from prostate cancer. And so it is important for us to be aware of it, and I believe it is important for us to screen for it. But right there and then is where the controversy begins. And as we're going to hear in a minute, screening for it is not always straightforward. And what you do about it when you find it is not always straightforward. And we will talk about that a little bit as well. Really, when you talk about prostate cancer screening, whether it be today or it be 10 years ago or even 20 years ago, you're talking about a screening platform that's predicated or founded on something called PSA, or using PSA, which is a blood test. And PSA is a blood test. PSA stands for prostate-specific antigen. That antigen, or prostate-specific antigen, is a molecule, a protein that is formed by prostate cells. But I choose that word very carefully. It is created by or produced by prostate cells, not just prostate cancer cells. And therein lies the problem, because the perfect marker in the world that Ken and I live in terms of screening for a disease is if you can test for a marker that says when the marker is present, you have the disease, and when the marker is not present, you don't have the disease. And unfortunately, PSA is not that marker. So unfortunately, we are stuck with a screening tool right now in 2023, 2024, that is an inaccurate test. And I want everybody on this call to understand that we use a test that we have to appreciate and fully admit right up front has real shortcomings. In fact, if you look at it purely through the lens of, is it a good screening tool for prostate cancer? The answer is it's not. In fact, it's a crappy screening tool. So if you take all men with elevated PSA blood tests, so when Dr. Zweig sends you to the lab, or I send you to the lab and you get your blood drawn for PSA and you get the result back on your lab result, you'll see on that lab result that it'll say there that the reference range for normal values is anywhere between 0 and 4. And then anything above 4 is considered abnormal. Well, first of all, it's important to appreciate that there's no magic that happens when somebody's PSA number goes from 3.9 to 4.1. In other words, the normal values are simply a mathematically derived normal range inside of which most men that have numbers within that range don't have prostate cancer. But there are men that have normal PSAs that are less than 4, that do have prostate cancer. In fact, if you want your first terrifying statistic of the night, about 1 out of 4 men with prostate cancer actually have PSA numbers that are less than 4. So there's a problem right there. Now, let's look at it from the other side of the coin, which is, what about all the men that have PSA levels above 4? And this goes to my point before about it's a crappy test. If we take all men with PSA numbers above 4 and we look for prostate cancer, no more than about 1 out of 3, and probably no more than really 1 out of 4 of those men actually have prostate cancer. So 25% of men with prostate cancer have normal PSAs, and only 1 out of 4 men, or 25% of men that have abnormal PSAs, actually have prostate cancer. All right, so the waters are already getting muddy. So you can see why it's challenging. Now, what else makes it challenging? What else makes it challenging is that there are some men who simply produce more PSA values that don't have prostate cancer. And we can't really figure out up front, day 0, who that person or that individual may be. But there clearly are some men that just have higher PSA values and higher PSA readings. Another thing that's confounding about the test, as I mentioned before, PSA, the blood test, the protein, is produced by all prostate cells. So the more prostate cells you have in your body, in theory, the higher your PSA number is going to be. So that means that as Ken and I and every other man on this call get older and our prostates grow as a natural part of age changes, we're going to have more prostate cells in our body, not cancerous, hopefully, but more prostate cells. And the more prostate cells we have, our PSA is going to be higher. So that means that as we get older, we should expect our PSA numbers are naturally going to increase a little bit. So that makes it challenging to try to screen for prostate cancer. What else makes prostate cancer screening challenging? Well, men will often come to my office and say, and they'll be sent over to see us because somebody drew a blood test on them and found their PSA number was high and they got sent in. And one of the first things they'll say is, I have no symptoms. And I'll say, thank goodness you have no symptoms. And this is the other thing that makes prostate cancer screening difficult. And that is because a patient is not going to have symptoms from prostate cancer until the horse is way out of the barn. In other words, prostate cancer, when it's inside the prostate, really doesn't create any symptomatology. But it's only when that cancer has left the prostate, has spread to other parts of the body, that the patient will have any awareness or potential awareness that they've got a problem. And by definition, once that's happened, we're already pretty late in the game. And so we don't want to let patients get late in the game. We don't want to let the horse get out of the barn. We want to catch it early, catch it while it's still inside the prostate, because then we have many options, or at least a few options, to try to address it. And we're going to talk about those options a little bit later this evening. So I imagine by now I've thoroughly confused everyone and said, well, okay, we have this crappy test. How do you possibly even begin to screen somebody for prostate cancer? Well, let's look at what the world was like prior to PSA testing. You don't have to go back all that far. PSA was discovered in the late 80s, FDA approved, I think, for use around 88 or 90 thereabouts, and really came into use in the urology community in the early 90s, around 92. If you look at prostate cancer prior to the PSA era, about 80% of men or more that were diagnosed with prostate cancer had metastatic disease at the time that they showed up. In other words, they didn't show up until they had symptoms. That's the only way anybody was able to figure out that they had a problem. And again, as I said a few minutes ago, by the time they show up with that kind of a problem, the horse is out of the barn. And that's a pretty dire situation in many cases. And so that was the pre-PSA era. And that's why initially when PSA came along, it was really heralded as this real game changer. That's going to be this amazing thing that we can now find all these men that early in the game and not have them have to wait until they've got metastatic disease to come to light. And in fact, that's really what happened. But unfortunately, led primarily by my profession, the pendulum swung too far the other way. And so what ended up happening is that every man with an elevated PSA was going to be taken, back then anyway, to a very exhaustive and sometimes invasive evaluation to look for prostate cancer. And then even more troubling is back in that early era of PSA testing, and really even back to almost 10 years ago, anybody that was diagnosed with any form of prostate cancer, any amount of prostate cancer, was taken immediately for aggressive therapy. And so we went from a situation where we had men that we weren't diagnosing in time, and that was a tragedy. And then the pendulum swung all the way to the other side, where we looked for everybody for prostate cancer and then, quite honestly, overtreated everybody. And so what happened is, in about 2013, 2012, 2014, PSA got a bad name. And that bad name was, quite frankly, somewhat earned. It was earned because, as I said, the test isn't particularly accurate. And it was certainly earned because my profession was too aggressive in dealing with PSA. And so everybody said, oh, you shouldn't be. All of a sudden, it went from everybody should get PSA testing. And then there was this sort of movement about nobody should get PSA testing. And like a lot of things in life, the correct answer is somewhere in the middle. And I think hopefully that's where we've kind of begun to swing the pendulum. I am, and this is a little editorial comment, but I'm a little afraid that at least for the last, say, 5 to 8 years, the pendulum did swing back a little too much in the let's not check PSA at all camp. And I'm hoping that we're going to find a middle ground. And I think that's really where we need to be. So with all that confusing comment there, what does that mean for the average individual and how they should approach looking for prostate cancer in their own life and consider screening? And I think what I would say is, and I wrote this in an editorial in about 2013, 2014 that was published, it's important to appreciate that the PSA blood test never killed somebody. The same cannot be said for the disease. So I don't think that we should not do PSA testing. I think we should do it, but we should do it in a rational way. And we should interpret the results of a PSA with, appropriate bias and appropriate grain of salt, basically. So we don't want to overreact just because somebody's PSA number is elevated. So how do you approach it? Well, if you look at the current guidelines from the American Urological Association, which is sort of the convening governing body of urologists, and you look at, and their opportunity and ability to assimilate all of the available data, the current guidelines would suggest that for the average male, they ought to consider doing a PSA blood test at about age 50. And assuming that it's normal, consider doing that blood test again about every other year. Now, there are some important alterations to that recommendation or caveats. And the first one is that you have to look at somebody's family history. So if you are a person who comes from a family where there is a strong family history of prostate cancer, first-degree relatives, meaning brothers, father, grandfather, uncles who have had prostate cancer, and certainly if anybody in that family has died from prostate cancer, I would argue you should not wait until you're 50 to think about getting a PSA. You're somebody that probably ought to get a PSA done, at least as a baseline reading, maybe around age 40. And then, maybe do it every couple of years, or certainly again at age 45, assuming both of those reads have been normal. Again, you could kick the can down the road, but then once you hit 50, you should do it, and you should probably do it every year. Now, there is another end of the spectrum, which is when, do you just keep doing PSA testing forever? And the guidelines would say that there may not be much utility in doing PSA testing after the age of about 70 to 75. Now, why is that? The reasoning behind that is that the data would suggest that if a man is going to be first diagnosed with prostate cancer after the age of, say, 75, they are unlikely to die from prostate cancer. And I think there's truth to that, but that's not because prostate cancer doesn't kill men after the age of 75. It's because if you look at the studies that data was assimilated in, it's because, well, men were dying by the time we were 80. In other words, they were dying of other causes. But it's a different world today. I always like to say I'm 57, and I like to say, 57 is the new 37, right? And 80 is the new 70. And so my point here is that we're all living, hopefully, with the help of fantastic primary care physicians like Dr. Zweig, and doing the recommendations that he and his colleagues make around, diet and exercise, et cetera, and staying away from, carcinogens and the smoking, that we're hopefully all living longer, healthier lives. And so I think that we can't apply a steadfast rule of you should not have a PSA test after the age of 75 to all men. Certainly, we have to put it in the context of that individual and what that individual's overall health is like at that particular moment in time. But I'll be honest, I've got some 85-year-old patients that are much, much healthier than some of my 45-year-old patients. And so we need to personalize those recommendations. But broadly speaking, the current guidelines would say PSA testing at 50 up until around the age of 75 and about every other year. Again, assuming you don't have a first-degree relative or a strong family history for prostate cancer, and as well, assuming you are not African-American, because the African-American population has a higher predilection to get prostate cancer, and not only to get prostate cancer, but to get tend to get a more virulent or aggressive form of prostate cancer. And so in the African-American population, much like the population that I mentioned where there's a strong family history, probably should be encouraged to be doing testing a little bit earlier and a little bit more often than every other year. And so, many primary care physicians that I work with, including, Ken and his group, will often choose to just simply add the PSA to the annual, battery of blood tests that are done looking at kidney function and screening for diabetes and liver function and some of these, and cholesterol and heart health, and just use sort of making that part of the panel. Another component to prostate cancer screening is a rectal exam. I mentioned earlier that 1 out of 4 men with prostate cancer have normal PSAs. You might say, well, then how did those guys get detected? It's in one of 2 ways. Either they had an abnormal rectal exam, so their prostate felt lumpy or bumpy, And that could bring it, could raise a flag that maybe something was going on. The other way, and we're going to get a little more confused about PSA testing here about what I'm about to say, is that there are actually what should be considered age-adjusted normal ranges. So I mentioned earlier, as men get older, their prostates naturally grow. The more their prostates grow, the higher their PSA number will probably be. But that means when men are younger and their prostates are presumably smaller, they're having less PSA in their bloodstream normally. And so what we've realized is that while the lab will report that a normal range is between 0 to 4, there is this notion of age-adjusted normal ranges. So for younger men, perhaps the normal range should actually be somewhere between 0 and 2.5. So if I have a 48-year-old male or a 50-year-old male that walks into my office, and certainly if they have a family history of the disease and they walk in and they say, I'm fine, but my family has a family history, so my wife's been driving me crazy. She says, I need to come see a urologist. So here I am, but I know my PSA is normal. It's 3.7. I'm going to look at that guy and say, yeah, I'm sorry to say your PSA is not normal, right? So I'm worried about that 45-year-old with a PSA of 3.7 or even, 3 probably in that scenario. Conversely, on the other side of the equation, the 75-year-old man, we might accept a PSA up to 6.5. In other words, because we know as they get older, their prostates are going to be growing anyway. They're going to have a higher PSA. So there is this notion of age adjusting, but it's not always clear cut. So, back to how do we screen? Rectal exam is important, but PSA and tracking the PSA over time can be very, very helpful also. Now, let's imagine that somebody ends up in my office because of either a strong family history of the disease or their next door neighbor just died from prostate cancer and they're in a panic and they just want to learn more about it. Or Dr. Zweig or one of his colleagues checked the PSA and it's abnormal. And so they get sent over to see me. What do we do then? Well, what we did 10 years ago and what we do today are very different. If you look at the landscape prior to, let's call it 2013, 2015, and still even today in some practices throughout the country, pretty much anybody that had an elevated PSA number would be taken straight for a prostate biopsy. And while a prostate biopsy is not the end of the world, there is certainly risk of infection. It's not the most pleasant experience, although in our practice, we do our prostate biopsies different than a lot of urologists in that we do them like a colonoscopy in the surgery center under a little sedation so that it's not uncomfortable. That makes us very popular because many urologists, particularly in the community here, still do them awake in the office, which is not a fun experience. My dad can attest to that.
It was amazing to me. I never understood that.
Yeah, I'll give you a quick sidebar. So my dad, who's now 86, 87, was diagnosed with prostate cancer about a decade ago, and he lives in Colorado. And at the time he was diagnosed, the decision was just to kind of keep an eye on it. And he had a urologist out there, and so anyway, he had, I think, 2 or 3 biopsies out there, and then ultimately, decided to come and see Andrew Yule, my partner, to kind of get further detail and evaluation. And so when he saw Andrew suggested that it was time for another biopsy, and so Andrew biopsied him and did it in the methodology that we use in our practice, which was to do it in the surgery center under a little sedation. And my dad's comment later that day when I saw him, he was staying with me. He flew out to Colorado and stayed at my house for a day or two during all this. My dad's comment was that he was probably going to go back and punch the urologist in Colorado in the mouth because he had 3 biopsies out there awake in the office and then had the one done here under sedation, and he just couldn't imagine why any urologist would do it awake. But
anyway. So barbaric, I didn't understand.
Yeah.
So, so finally, thank God for you guys.
It's just I don't know. It's just for us, it's made sense in our practice for the years now. So in any event, so in years gone by, everybody that had an elevated number was kind of like straight to biopsy, and it was very much all we had was a hammer, everybody was a nail, and see you next week for your biopsy. But what we've come to understand is that, as I said earlier, is that as a profession, we were way too heavy-handed. We should not have been doing that, and we've really migrated away from that approach. Now, that doesn't mean that when you come to my office with an elevated PSA or a concern around a family history that we're going to say, don't worry about it, get the heck out of here. But what it does mean is that we're not going to tell you right off the bat, we'll see you next week for your biopsy. what we will do, in addition to assimilating the history and the exam and all that, is we will probably look at one or two other markers or methodologies to better assess how concerned we should be. The one that we deploy the most is what's called a prostate MRI. And for those, many of you in the audience have probably had MRIs for other things, hip, knee, back, shoulder. It's basically an imaging study that's done in the radiology department. It's non-invasive. And the interesting thing is that over the last 4 or 5 years, as we've begun to use MRI more and more in this vein, we've learned a lot about the ability of MRI to help us decide who we should be concerned about. Now, that doesn't mean that somebody with prostate cancer will always have an MRI that's abnormal or that's normal. It doesn't mean that anybody with a normal MRI doesn't have prostate cancer. What it does mean, though, is that if you've got prostate cancer that we really need to know about, in other words, it could potentially be lethal, we're very, very likely going to see at least a suggestion of that on the MRI. So we lean pretty heavily in my practice on MRI. Now, MRIs, there's I don't want to say operator error, but it is operator dependent. In other words, image quality matters, and the radiologist who's reading the MRI matters as well. And so, we do all of our studies, if at all possible, at the Virginia Hospital Center. We have real state-of-the-art MRI technology at our disposal, and our radiology group has three radiologists who really focus and specialize on specifically reading these types of images. And so, with that kind of selection, I think we feel confident about using MRI as part of our screening when we have a patient who has an abnormal PSA. There are some other tests that can be done as well. One of the ones that we will sometimes use in our practice is something called an exosome test. It's actually a urine test that we can collect in the office, just a urine specimen, but it's looking for some genetic components that tend to elevate in the urine in somebody who has prostate cancer. Now, again, like MRI, exosome, like PSA, these are not binary results. In other words, it's not like your exosome comes back, it's positive, it means you got prostate cancer. Your exosome's negative, it means you don't. MRI, positive, you've got prostate cancer, it's normal, you don't. Not at all. But it helps give us more evidence as to who we should be concerned about. And so if we have a patient who has a PSA number that's concerning, and that maybe has been checked once or twice and remains concerning, they do an MRI, their MRI looks a little worrisome, and or maybe an exosome that could potentially look worrisome. That's the patient that we're then going to recommend for biopsy. But I have many patients, I suspect some on this call, who have come to me with elevated PSAs, and I've said, look, your prostate feels normal. You've got no family history of the disease. We did an MRI. Your prostate looks okay. Why don't we kick the can down the road 6 or 12 months, and we'll follow your PSA a little bit, and we'll see where it goes. And sometimes that PSA stays elevated, but rock solid stable for years and years and years. And we just continue to follow those men. So I don't want anybody on this call to think just because if they were to eventually get a PSA number that's elevated, that they're immediately going to get a biopsy. But there certainly are men that we will recommend biopsy for and where it's very appropriate. But we want to be selective in who we take to biopsy. As I mentioned earlier, we do our biopsies a bit different in that we do them under sedation. This allows it to be a very comfortable experience for the patient. It also allows us to get a very good sampling of the prostate. If we have seen an abnormality on MRI, we use that to guide the biopsy. So we're sure that even though we're going to sample the whole prostate, we're going to make sure that we're sampling the area of suspicion predicated by the MRI. So I think that's important as well. And then, we go from there. Many biopsies will come back negative, fortunately. And when they do, we're usually going to just recommend that patient do another PSA blood test in a year, and we'll just kind of trend it and see where they go. There are patients that a year later or 2 years later, 5 years later, the PSA number's going up, and we may end up doing another MRI. We may do another biopsy. But on the other hand, there's some men that we can just simply follow. And so that's how we approach it in our practice. And, that's kind of the screening methodology around it. What I'd like to do is maybe take you through, kind of shift gears a little bit and talk just for a few minutes here about what happens when somebody does have a positive biopsy. In other words, what do we do today to address prostate cancer? And then, from there, we can hopefully open it up for some questions and go into that portion. But in any event, let's imagine that we've gone through the paradigm and the algorithm that I just talked about, and now, you know, a week after the biopsy, we get a result back from our pathologist, and they say, lo and behold, there's prostate cancer. What then? Well, much like the screening conversation, this is a hard conversation as well, because the waters are murky and muddy. The path is not always well defined. And so, you know, we have to really dig in. And generally speaking, and again, some of the people on this call may have heard this from me, I will tell you that the devil is in the details. And so not all prostate cancer is the same. And so we want to look at the specifics of that individual's biopsy and their cancer. And we then want to overlay that on the foundation of the individual themselves, meaning what is their overall health like? What are their expectations in terms of quality of life? Their, you know, what's the genetics around their longevity suggest for them? And you know, what is their risk tolerance, basically? And then we can begin to talk about what we're going to do about the disease. But speaking in sort of hypotheticals, if we get a biopsy back on a patient and they have a small amount of disease, what we would call low volume, meaning there's not much there, and if what's there not only is small, but under the microscope, the cell type is relatively non-aggressive, then these are men that today we would encourage strongly towards something called active surveillance. Now, I mentioned to you guys earlier when we were talking about the historical annals of prostate and prostate cancer that we overtreated the disease, and we absolutely did. The scenario that I just gave you, low volume, low risk disease, these are patients that years ago would have gone immediately into treatment. But today's world, we try not to overtreat. We certainly want to treat those patients that need to be treated, but we're also going to be very measured about who we offer treatment to. And so somebody with low volume, low risk disease, we're going to probably recommend active surveillance. Active surveillance does not mean go away and come back when you got symptoms because your cancer has spread. Not at all. It means we need to actively surveil you. And so what that means is generally we're going to want to track your situation and your status by doing PSA exams on an annual blood tests on an annual basis. And we're likely going to recommend, regardless of what that PSA is doing or what your rectal exam is feeling like, we're going to probably need to repeat a biopsy on an annual basis or some interval to track the actual disease within the prostate. I will tell you, broadly speaking, that well more than half of the men that we diagnose with prostate cancer today in our practice go on to active surveillance. Okay. So that means that well more than half of the men that we make the diagnosis in, we're going to tell them, take a deep breath. This is not life-threatening for you at this current time. It's not going to impact your quality of quantity of life as it currently exists, but we want to be on top of it and make sure that it doesn't begin to change in ways that suggest that it could impact quality or quantity of life. And at the time that it gets to there, then we're going to be ready to act and to intervene. And so, you know, I want to just sort of set the table for, or in the historical context, that just because you got prostate cancer does not mean you're going to get, you know, smacked upside the head with aggressive therapy. Now, there are definitely men that do need aggressive therapy, however. Who are those patients? Those are the patients, it's the minority of them that are positive, have positive biopsies, but it is those patients that have aggressive disease, meaning they've got a high volume of disease at the time of their diagnosis, and or the grade of their disease, what the cells look like under the microscope, appears more aggressive. Perhaps they're younger. Perhaps they have a bad family history of the disease. But those are patients that we're going to be then encouraging towards treatment. And when you talk about treatment, there are two main well-traveled roads in the treatment world. And then there are two roads that we don't travel in very much, but I'll mention them here for completeness sake. Basically, the well-traveled roads are you can nuke the prostate, so radiation treatment, or you can go take it out, which means a radical prostatectomy, which in my hands is done using robotic technology to make it a less invasive surgery, but it does mean removing the whole prostate. The less traveled roads are using technologies to either freeze the prostate and kill it off that way, something called cryotherapy, or the other end of the temperature spectrum, technology that heats the prostate to high temperatures and kills it off that way. That's called HIFU, high intensity focused ultrasound. Cryotherapy, the freezing, while FDA approved, it hasn't gained a ton of traction. It does have certain applicability, but it's in a really select group of patients. I won't go into the details of that here, but for the sort of the naively, the initially diagnosed patient that needs treatment, cryotherapy is not going to really be on our list. The HIFU, the heat therapy, I think is a technology that's very interesting. It's been around for a long time. In fact, I was part as a resident at Georgetown in the early 90s. We were part of the original FDA trials around using HIFU. Back then, it wasn't great. It has subsequently finally been approved by the FDA a few years ago, although even the FDA wasn't thrilled with it. So the approval that they ultimately issued was not to treat prostate cancer, but was carefully chosen wording to ablate prostate tissue. And that was intentional because while it certainly can kill prostate cancer, there's some concerns around side effects and things like that. So HIFU, though, is evolving. I think we're going to see more and more about HIFU in the coming years, because the thing that is exciting about HIFU is that it is very, very targeted, which we're not able to do really around radiation, and certainly with surgery. When we're talking about surgery, we're talking about removing the whole prostate. So if you think about the breast cancer world, where years ago when somebody had breast cancer, it was mastectomy, removing the whole breast. And over the last several years, decades really, there's been a move to breast preservation, or what is called a lumpectomy, which means just remove the tumor, try to leave as much healthy breast tissue behind as you can. Prostate really hasn't allowed that in terms of the therapies, but we're starting to see that more and more now with some of this HIFU technology. And so I think as the technology has evolved and our imaging has improved using MRI, and there's some really interesting and exciting new ultrasound technology that's just come online in the last year or two, I think we're going to be able to target better. And if we can target better, and we may be able to start doing more and more of the high intensity focus ultrasound. So I think more to come on that. Not quite prime time yet, but it's sort of the next exciting chapter in the management of localized prostate cancer. I was not intending to go into the weeds on the side effects of radiation and surgery. I mean, I certainly can if patients have questions about that. That can be a multi-minute to hour-long conversation in of itself. But in any event, that's sort of how we approach those patients. It's, as you can tell from the way I've described it, it's certainly not a one-size-fits-all. You cannot have a knee-jerk reaction to how you're going to treat a patient with prostate cancer. You have to individualize it. It is very much a shared decision that, as the treating urologist, I have to be quite rabbinical in laying out what is out there and what's available, and then help the patient and the patient's family begin to make decisions that make the most sense for them, rather than just saying, you have this and here's the way we're going to go about it. I think what I'd like to do, Ken, if it's okay with you, is maybe stop there. I see some questions have started to come in, but I know you're emceeing, so I don't know, maybe is it reasonable to open up to questions at this point?
Great. Yeah, make sure we have some time. I have a number of questions myself as well.
Okay, great.
More for clarification or get your take on it, because there are so many nuances, and this is so difficult and so unclear for so many people from the very beginning of just screening all the way to the point of diagnosis and then what treatment to use. And yeah, so I go through this many times and always try to read the newest and latest and greatest and find out what's going on. Yep. And so why like I said, I have a number of questions on some of the things that you said, just more for clarification, really, on what you think versus what we might do a little bit more in the primary care setting. But yep, let's start with what the patients had. So there's a number of questions come in. The first one is very interesting, and it prefaces that with a weird question. It says, are there any studies with dogs trained to detect prostate cancer? I've heard
Uh,
stories about this. I've never seen it actually used.
yeah, that's a great question. And full disclosure, I have no idea. I have not ever heard of it. It wouldn't surprise me. I mean, if that came along, I know that there's a lot of emerging enthusiasm in sort of healthcare around this notion of wet biopsies. In other words, using blood samples to screen for a variety of asymptomatic malignancies in very early stage. And there is some enthusiasm for that as it pertains to prostate. So I think that it's not, the short answer to the question about dogs is I'm not familiar with it, but it wouldn't blow me. It would blow me away, but it wouldn't shock me if there is. But I think that really what you're asking there are there other things that can be looked at? Dogs that's looking at using pheromones, obviously, the smell type, highly trained. But then in wet biopsy, it's looking at certain tumor markers that you might be able to find very, very early. So
my understanding on those wet biopsies or liquid biopsies, what we're going to call them, is that they have some promise for a number of cancers, but it's usually the more faster growing ones that tend to put out more targets.
That's exactly right. Yeah, it's got to be, it's got to be moving quickly and breaking through, cell membrane barriers and creating some destruction, even though it may not be symptomatic, for it to show up in the blood. That's right.
It is exciting. Not there yet, though.
Yep.
And then this is a great question. What is the current status of prostate artery embolization in the
treatment of prostate cancer? Yeah, it really doesn't have a role in the treatment of prostate cancer. So prostate artery embolization, just for everybody on the call, is a methodology done in interventional radiology, where the interventional radiologist will, using imaging, occlude or obstruct the blood flow into the prostate. However, even its use primarily has been in attempts to manage BPH, although I don't think the data there is all that compelling either. I would certainly not let anybody ever embolize my prostate, either for an enlargement and certainly not to treat prostate cancer. It can be used in some men who have a lot of bleeding issues from enlarged prostate. It can be used in conjunction with other methods to treat enlarged prostate, so it can be part of a treatment regimen or algorithm. But as primary therapy, and certainly as primary therapy for prostate cancer, unless it's really advanced prostate cancer and they're just having bleeding from their prostate cancer and it's kind of an end of life discussion, it may have a role there. But that's about it. It really doesn't. As primary treatment for a newly diagnosed, early detected prostate cancer, it does not have a role.
And then obviously this is near and dear to my heart, can you discuss any methods to help prevent prostate cancer?
Yeah, well, I may throw this one back to you because you're probably even more evolved on this topic than I am. I suspect you are. I will say that the urologic literature is not particularly strong on any absolute do's as it relates to prostate cancer. So what I mean there is patients will sometimes say, okay, should I be eating 50 tomatoes a day, or 400 pounds of salmon a day, or something along those lines? The data is not really good there. What we do know, though, is that certainly if you look at area populations that have demographic populations that have lower rates of prostate cancer, and I'm specifically talking now about like some Asian populations, in their native country, in their native culture, with their native diet, and when they then move to a more westernized diet because they've come to the States or somewhere else, you tend to see prostate cancer rates rise. So we know that the Western diet, as a general rule, isn't great. Here's how I answer the question when it's broached to me, and it's broached to me often. Here's how I answer the question in my office. But again, can I be really interested actually in hearing your take on this? What I tell my patients is that, generally speaking, whatever is good for their heart health is likely going to be good for their prostate health. And so I try to focus them in that way. So, the kind of counseling that I imagine you do, increasing plant-based diets, certainly staying away from the carcinogens that we can stay away from, like, smoking never helped anything. Has it been directly causally linked to prostate cancer? No, certainly not in the way that it has been linked to lung and bladder and colon. But that's how I go about it. But it's not like you have to do this or you need to take some, there was enthusiasm years ago around zinc and you should take zinc supplements. And then the data there kind of soured. Then there was enthusiasm about taking omega-3 supplements. And then interestingly, then there was a study that actually said that if you were supplementing omega-3s, that the prostate cancer risk actually might go up rather than down. I think the take home that I got out of that was that if you're it's really great to get omega-3s in your diet, but you probably need to do it by eating natural sources of omega-3, like, just eat more fish. That you can't, another sort of, I'll call it a Mordkinism, but something that I say is, as I think what I've learned and what I've appreciated, and again, I'd like to get your take on this, is you can't supplement your way out of a bad diet. So, if you want to try to do this right, do the things that are going to be good for your heart, and they're likely going to be good for your prostate as well.
Absolutely, I would say you can't bypass nature, and so you should recognize, omega-3s are great when they come from fish, and vitamins are great when they come from vegetables and whatnot. I mean, you want to get them directly from the source, and you should recognize and be able to see and know what it is that you're eating in its natural state as much as possible. So so I say it's always comes down to four things. That's heart health, brain health, longevity, preventing cancer, whatever it is. It's eat right, exercise, get enough sleep, and don't be stupid, which is don't smoke, don't drink too much, stay with the carcinogens, just take care of yourself. And those things that applies across the board. So, but I guess my take for that as a add-on to that statement is, what is your take on 5-alpha reductase medications for prevention of prostate?
Yeah, so that's a really interesting world. So what Ken asked there is a class of medications out there which were originally developed to treat enlarged prostates. And they work by shrinking the prostate, and they will actually, if you take these medications, and the medication that most people know is finasteride is the generic, and the trade name is Proscar. If you take that medication, it will, over about a 6-month period, reduce the size of a prostate by about 25% in total volume. The way it does that is by blocking the conversion inside the prostate of testosterone to dihydrotestosterone. It blocks the enzyme, the 5-alpha reductase enzyme, which is what converts testosterone to dihydrotestosterone inside the prostate. And dihydrotestosterone is something that causes the prostate to grow. So there was enthusiasm several years ago that if you blocked the growth of prostate, you might actually inhibit the development of prostate cancer. And so there was a very, very large trial that was done. And I think when it was initially launched, the hope was that this would be the end of prostate cancer, that we would just put all men on finasteride at some age. And by the way, finasteride at low dose is a medication that some people might know because you take it for rejuvenation of hair growth. So it was going to be this wonder drug where you would take this medication, you would have small prostate, so you would never have a problem peeing, you would have full luscious heads of hair well into late in life, and you would never get prostate cancer. And it was just going to be nirvana. But the study was actually stopped early because some of the analyses around the initial data that came in, and these studies went on for years, was that while it was true that in the men that were taking the finasteride, that there was a lower rate of prostate cancer in the treatment group versus those that were not on treatment, that if you looked at the men in the treatment group, in other words, the men that were getting the finasteride, that smaller number, but those men that did get prostate cancer tended to show up with a more virulent, a more aggressive prostate cancer. So everybody was like, uh-oh, we better stop giving everybody finasteride because we're creating somehow more aggressive prostate cancer. Where are we today? Well, that study and that population of patients have been looked at now 10 different ways to Monday. And I think where most people have landed on the data is that the medication, and this is now finally I'm getting to answer the question you asked, Ken, is what's my take on it in terms of prevention, is that most people I don't think should be taking it if their intention is to prevent prostate cancer. In fact, I sort of don't even consider the medication within the prostate cancer milieu. What I do is I use it in patients who have an enlarged prostate, who are very symptomatic from enlarged prostate, because I think it certainly in many men it works well there. But there are some caveats to that, and the caveats are that if you're going to go on this medication, we absolutely should know what your PSA is before you start it, because we want to make sure you're not somebody that potentially has prostate cancer that we haven't looked for. Because if we put you on this medicine, we may be, I don't know if accelerating it, but we're certainly going to unmask it. The other thing is that anybody that goes on the medication should be aware that these medications have a side effect on PSA, and that they will reduce the PSA blood value by 50%. Now, that's not necessarily a good thing. That doesn't mean that if you walk into my office with an elevated PSA and you say, well, how do we get my PSA number down? Can you just give me some finasteride? The short answer is, yeah, I can get your PSA number down 50% if I put you on finasteride, but it's an artificial number. In other words, anybody that's taking that medicine that gets a PSA blood test done, you have to multiply the result from the lab by 2 to understand what their true PSA is. And so I hope that's kind of a long way of answering your question, but the short version is I don't think it's particularly helpful in preventing prostate cancer. And I don't know any urologists right now that are using it in that vein.
But I also, to be clear, you don't believe that it actually, that I've learned, my take on that also is that those more aggressive cancers that they thought it was causing, when they looked at the data again, they thought that it was actually more of breakthrough cancers that would have broken through anyways, and that would have happened. And so it's not like it's increasing.
Good point. Yeah, I think that, right, exactly. In the same way that the study didn't prove that it proved that it didn't really seem to prevent prostate cancer, when patients were showing up with more aggressive prostate cancer, I think we should also understand that it's not that the finasteride was causing prostate cancer or causing more aggressive prostate cancer. I think really what it was doing is perhaps just unmasking those men a little bit earlier than they likely would have been discovered. So yeah, it is for men that probably need finasteride, or at least should consider finasteride because they have an enlarged prostate. They shouldn't shy away from it because of this conversation around prostate cancer. It's a perfectly safe drug as long as we know what their PSA is before they start the medicine, and then we track their PSA while they're on it, just like we would otherwise. But when we get a number back while they're on it, finasteride, we should just multiply it by 2 to know what their real PSA is.
And then another question is that many men are concerned about the sexual function of treatment effects.
Yeah.
What can you say about that?
Yeah. So, I said before I wasn't going to get into the weeds around treating prostate cancer, but here we go. So there is no question that when somebody considers undergoing treatment for prostate cancer, whether that be surgical removal of their prostate or radiation to their prostate, or even using the high intensity focused ultrasound treatment, that negative impact on their sexual function is certainly a potential. Now, the potential for that varies on a number of factors. Certainly the therapy itself, it varies. So the worst outcomes in terms of maintenance of sexual function are going to be with surgery, if you compare that to radiation. But it doesn't mean that everybody that gets radiation maintains their sexual function. They just tend not to degrade. It doesn't tend to degrade as quickly as it does with surgery. Because if you have surgery, your worst day for your sexual function is the next day. And then hopefully as you recover and heal from your surgery, you will get some of your function back. With radiation, when you first get your radiation, things are pretty good. A year later, 2 years later, as the radiation impact begins to take hold, that's when we may begin to see a decrease in sexual function. The other thing to consider, though, for these patients is what's their sexual function like at the front end of all of this. And so, admittedly, a lot of the men that come to our office that we start evaluating for the potential for prostate cancer and may potentially make a diagnosis of prostate cancer in don't have great sexual function to begin with. And so, the reality is that treating prostate cancer, whatever the modality is, never made your function better. So if you show up with marginal function at best to begin with, you absolutely need to expect that when you come out the other end from treatment, that is going to be significantly negatively impacted. And that's just you know, the reality of the day. And you need to begin to then weigh sort of priorities. Now, you know, we have other methodologies to treat erectile dysfunction after treatment for prostate cancer. What I tell all of my patients when we talk about surgery is that, you know, if you don't get your function back post-operatively, it does not 100% mean that it is the end of your sexual function. But what it does mean is that we're going to have to use other methodologies to help you there. And it may not be business as usual. So your function will not be as good as it was before we started. And we just have to know that you know, you need to go into it with eyes wide open that you know, it's going to take a hit, and it's going to take a hit to the negative.
And I think again, just a couple quick questions. From my standpoint, just going back to the DRE, the digital rectal exam, most of the things that I've read are that most groups don't recommend that anymore, except in, you know, select situations, and that there was some studies that showed that it might actually worsen outcomes because prostates are nodular and bumpy, and you're going to find stuff that isn't real necessarily, and that a lot of times that's going to lead you down a path where you're going to do more procedures and more testing and things that can have worse outcomes. So I can comment on that.
Yeah, I mean, I think that again, you know, a rectal exam never killed anybody any more than a PSA blood test did. It's what you do with that data that matters. So I think in the era of you have an abnormal rectal exam and or you have an abnormal PSA, you're going straight to a biopsy. Yeah, I could see an argument that says that maybe a rectal exam wasn't great because we just knew that everybody was a nail. You're all going to get hit with a hammer. But in today's world, if you come in, as I said, in very similar to an elevated PSA, if you've got an abnormal rectal exam, we're not running off to do a biopsy. We're going to go back to those other, you know, methodologies that I mentioned around MRI in particular. And I have a patient I saw today, big nodule on his prostate. I mean, I think if, you know, if you had 10 medical students shadowing you in the office, they go take a feel of that guy's prostate. That's an abnormal exam. MRI looked fine.
Adverse outcome, by the way.
Yeah.
For the patient.
Exactly. But MRI was fine. MRI showed this was just a benign nodule in his prostate, nothing worrisome, no characteristics worrisome for prostate cancer. He's got a normal PSA. We're just gonna keep an eye on him. So, you know, I still am in favor of a rectal exam. I know there's argument out there against it. Like I said, it's never killed anybody. I don't see any harm in doing it.
And the last question here is any effect of alcohol or animal protein? I think we sort of touched upon that.
Yeah, I mean, alcohol, no specific effect on prostate cancer, you know, in terms of, you know, increasing the diagnosis or whatever. But back to, you know, the analogy that you gave earlier about, you know, what are the general lifestyle health things? You know, alcohol, I think as time has gone forward, I've soured more and more on alcohol over time. I myself don't drink much anymore at all. I just haven't seen much data that says that it's particularly good for much of anything. I mean, look, you know, you want a glass of champagne, a glass of wine every once in a while. I don't see a problem there, but you know, anything beyond that is probably not a great idea. And then as far as animal protein goes, I mean, I think that's an interesting question. I actually am pretty bullish on protein intake, and that I think it is really important to maintain muscle mass and all that. So I'm not an anti-protein person at all, and I don't know of any data that says that protein in and of itself would increase the risk of prostate cancer.
Right. Yeah, so I think there's probably a lot more to talk about, but we're out of time, and I want to respect your time and everybody else's. So thank you so much for coming. This was a wonderful talk, very informative, and really appreciate it. Thank you so much for giving us your time and knowledge. And thank you to everybody else also for joining us. I hope that was helpful. I hope you got to all your questions. And I hope you all have a great night. So
thank you.
See you. See you. Right. Thanks
Appreciate
so
the
much.
opportunity. Thanks a lot. Bye.
Take care. Bye.